All right. Okay, and we have how many people online?
So far, just one.
Okay.
That might join us. We go.
On the little tile, maybe you can move it.
Yeah. There we go. Okay. All right. So maybe we'll just get started and if we have people join us, then we'll do a little review. All right, so I'm Dr. Sandra Rodriguez. I am an adult and geriatric psychiatrist. I have a private practice here in Miami Lakes. And Father Chofi asked me to talk about issues related to mental health and Catholic bioethics, obviously. And we really wanted to focus on current issues. When you talk about bioethics and mental health, it's such a broad subject that I asked Father to really tell me what he wanted me to talk about, because it's such a broad subject that we would just, it would be a whole series in itself. So we're focusing on today on gender issues. Father will talk to you guys about physician-assisted suicide and euthanasia later on in the course. And so this is just a very quick overview. I think you guys have gone over this, the core principles of bioethics, and these pertain specifically to medicine, and I'm gonna just kind of put them in context in terms of mental health, psychiatry, psychology, so that we can later compare and contrast and go into how these affect the issue specifically about gender ideology and everything that's going on in our current environment. So as in a general overview, we have the principle of the respect for autonomy. And these principles really are very pervasive and are things that I have to be really conscious of on a daily basis in the practice of psychiatry. And really the main issue is always between autonomy and beneficence. Those are the ones that I mostly deal with. But for example, respect for autonomy is the patient's right to make an autonomous choice, and it is closely related to competence. Now, competence is a legal term. Hi. Welcome. So competence and informed consent are two things that within psychiatry and mental health are daily. It's like my daily bread. It's very important that the patient does have the right to his autonomy, but then I have to contrast that to whether the patient is competent to make sound decisions and to make decisions that are going to be good for them, for their outcomes, and whether they have the competence to make a good and informed consent, to make decisions that are going to be good for them. The principle of non-maleficence is the duty, and again, I'm reviewing this in the light of my kind of practice, right? So you guys have discussed it with all other subjects, but within psychiatry, non-maleficence is really the duty of the psychiatrist to avoid harming the patient. So this one is really closely related to our Hippocratic Oath, first do no harm, right? So, and we have, we can go over examples of this if you guys want to discuss specific psychiatric issues at the end, because we're going to have time, then you can, we can ask and have discussions related to this. Beneficence is to prevent or remove harm and promote well-being. So in psychiatry, the example that I usually give is the psychiatrist's duty to protect the patient if they are not competent or not able, do not have the capacity to make good decisions for themselves. Everyday example for me is whether someone is suicidal and they can make the decision of whether to come into the hospital or not. So with the principle of beneficence, my duty is to make that decision for the patient if I determine that they don't have the capacity to make that decision. And so we bring them into the hospital involuntarily. So that takes away the decision from the patient, and that's acting with this principle. That's just an example. And if you guys have any questions, then we can go over other examples. The principle of justice is extremely broad. So it's it involves everything with medical care, access to care, economic, social policies, protecting patients' best interest, and of the individual, not only society at large. So I'm going to go ahead. So those are just that's a very broad overview. And as we discuss all the gender issues, I want you to think back on these, and we're going to see how really we're at odds. We're at odds. The medical population and Catholic bioethics and our understanding of the human person and the anthropology of the human person are completely at odds. And we're going to put this into context later on. Okay. So the issue of gender dysphoria is something that is very much on everyone's minds. It's something that has gained a lot of traction. There's a lot of issues with involving treatment.
It's the one where someone's born without any, and then they make them into a girl, but they might have actually been a boy.
No. Yeah.
Different one.
Yeah. Yep. That's an important distinction, because we're not talking about genetic congenital issues. There's hormonal issues when an in vitro that change up the expression of genes. And so if someone is born with ambiguous genitalia, that's a 100% medical condition. And there's a lot of decision-making issues with the parents at the beginning, because if it's ambiguous genitalia, then they really can't differentiate. And back in the day when we didn't have genetic testing, it just brought all kinds of problems, because the parents would decide early on to assign a sex, and then they grow up and it turns out that they were the opposite sex that was assigned to them, that's a whole nother condition, and that's not what we're talking about today. Yeah, but it's an important one. And I think even in the diagnostic criteria from before, and we'll get into that, they did make that distinction specifically. It's not even there anymore because it's separated. So we're going to go through some definitions. We're going to go through the human anthropology and gender and some ethical implications, mental health treatment considerations, and the ethical implications related to those. And we're going to do a case discussion. If we can, and if it's, the last time I had trouble with the audio, but I have a couple of little videos that are quite helpful as well. Welcome, Dayan Machado. You're probably muted, but
Hello, I'm here.
Hi,
Good morning.
¿cómo está, padre?
Bien, un saludo a todos en clase.
It's good to see you here. All right, so we're
Dr. Sandra, now I recognize you.
Of course.
I wasn't able to see you, but now I see you. What a wonderful coincidence.
Yep,
This is.
absolutely, yes. I'm glad you're taking this course. So I used to live in Tampa, so I know Father from the Diocese of St. Petersburg. Así que saludos. Okay, so we're just going over some terms and then we'll get really into the diagnosis and treatment part and all the bioethics issues related to that. So with gender, the definition is the psychological and cultural characteristics associated with biological sex, and it's an individual's awareness of whether they're male or female. Sex really is determined by biology, okay? So you're either XY or XX, and this is something that is determined really biologically, it's a fact, but then we get into the discussion of whether this can be changed or not, right? And then we'll go over the gender identity, gender dysphoria, and the distinctions between those. And gender transitioning is someone who is actually going through the treatment of switching from male to female, female to male. And transsexual is versus transgender. So transsexual, actually, I believe they're trying not to use that term so much anymore. And actually, these terms change like constantly. Like it's very hard to keep up with the correct terms. But in my understanding is transsexual is someone who is actually undergoing the treatments or has undergone the treatments. And transgender is someone who just identifies as the opposite sex, okay? So I wanted you guys to have this, and I'm going to send you actually the updated slides, but this is just so that you can compare between the differences between before DSM-5 and after DSM-5. So this is the Diagnostic and Statistic Manual for Psychiatry. This is where we really have the definitions of our mental disorders, and basically so we can all know that we're talking about the same thing, okay? So we use the DSM, and in 2000, this was the most up-to-date version in the year 2000, it was described, these issues were described as gender identity disorder, which was a strong or persistent cross-gender identification, not merely the desire for any perceived cultural advantages of being the other sex. And in children, it was a disturbance manifested by these, repeated desire to be or insistence that he or she is the opposite sex. And it, just goes through all of the different, excuse me, all of different criteria. And if you look at C, the disturbance is not current with a physical intersex condition. So they did make that distinction in the DSM-4. Now, when you and that it's not caused by other psychiatric illnesses. But in the DSM-5, which was an updated version, they actually, I think one of the most significant changes was that they took the word disorder out. So they changed it to dysphoria, which means it's more of a feeling. And that's one of the biggest differences, that they actually took it out of the sexual disorders chapters and made a separate chapter just for gender dysphoria. Mm-hmm.
Is this instrument being politically correct?
Absolutely, in my opinion, absolutely, yes. And because also it brings, so this is where we bring in the principle of justice. So it brings in all other implications about treatments, access to care, physiological or psychological treatments, all of that. And we'll come back to that, absolutely. And outcomes. That, you know, if you're doing a medical treatment, you want to have good outcomes, but unfortunately, what we can tell, the outcomes are not good for the treatments that are proposed. But it started with this, it didn't start, but this was one of the big markers for this whole, I guess we can call it agenda, that the diagnosis was literally changed. And now it is defined as the distress that may accompany the incongruence between one's experienced or expressed gender and one's assigned gender. Now we can argue all day. Were you assigned a gender or were you created with a gender? And what do your chromosomes say, right?
I don't think there's an argument here whether you're assigned or created. You have a gender.
You have a gender, yeah. And that's why it's so politically charged, socially charged. This is like a very controversial subject, right? Because we are completely at odds. If we're coming from a Catholic anthropology of the understanding of the human person. So it's just completely at odds. So myself as a psychiatrist, I am taught the complete opposite of what we believe in our Catholic faith and Catholic bioethics and the way we would like to practice medicine. So that's the big distinction, that they took out the disorder and they put it as that although not all individuals will experience distress because of not what they think they are and what they actually are, the distress is because they cannot get the desired interventions. So let that sink in for a little while. Okay, we're not talking about, and the way I explained it in the previous, in last year's lecture was, what we're talking about is that I'm a female, but I think I'm a male, and my issue is not that I think I'm a male. That's not causing distress. What's causing distress is that I believe I want a treatment and I can't get it. As opposed to, you really think you're a male and that's not a problem? No, that's not the problem. The problem is I can't get the treatment. So this is very extremely politically led. Yes.
I think I brought that up 2 weeks ago, really briefly, like with the contemplation of little people. Some of them they don't consider it a disorder.
Mm-hmm.
So it's like where you draw the line.
Exactly.
So that's a big conversation.
Yeah, and we can also bring in diagnoses such as body dysmorphic disorder, where people truly believe that something's wrong with them, and it's a disorder of how they see themselves, really, and it's, or anorexia even, that they really truly, they look at themselves in the mirror and they're emaciated, but what they see is an obese person. So really it's hinging on really not being in touch with reality. But if you ask mainstream psychiatrists, they're going to say, no, it's not to, I can say this here freely because this is what we're talking about, but I can't say it's delusional thought with colleagues that would, I mean, I would be, I don't even know what would happen. I cannot say that it's delusional because they believe it's not delusional. But in my opinion, it borders on delusion because you really truly believe something that is not reality. And that is the definition of psychosis.
So if they don't believe that it's delusional, what do they believe it is? How do they?
That it's a disorder brought about society. because society isn't going to give you what you want. So I'm a male stuck in a female body. That's not the problem. The problem is I want treatment and I can't get it.
See, I see an illness that society seems to be, everyone in society seems to be getting. It's as common as a common cold, is this idea of choice.
Yes, autonomy.
It's a choice, and because we can make the choice, we can do it. And so there's no central boundaries for choice.
Right.
It's all about the individual.
Individual, absolutely.
And I think that's the ism today that's destroying today's society.
Absolutely.
But that's just my.
But it's true, and that's why I started with the core principles. So we're really at odds in terms of the patient autonomy. This is what I want. This is what I think is better for me, versus my duty to protect the patient, and and in my opinion, not affirm what I think is going to be causing harm. So so they have their autonomy and I have my duty to do what's right for them. And in my opinion, this is actually disastrous, to go through some sort of transition treatment. So it really is, it's completely at odds. And we can talk about this regarding contraception. That's totally bad medicine. It's bad medicine. It's, you get blood clots, you get pulmonary embolisms. There's just a whole liver cancer and all these things related to contraception. But the patient has the right to choose it, right? And I have the duty to say, okay, well then, but I'm not prescribing it. I'm not recommending it, and I'm not, because I think it's harmful. It causes harm. So this is where we're at. This is what, that's why it's so important to keep in mind the principles, so that you can see how they come in and out of the subject, because we're also talking about the do no harm when the treatments actually do harm. And that's not just an opinion, as you'll see, research actually shows it, that the outcomes aren't good. So going back to the DSM, so it's no longer classified under sexual disorders. They did have, in the DSM-4, they did have specifiers regarding sexual orientation. So you could be transgendered, or you could have gender identity disorder, and then it would have the specification of male but still attracted to female, or male attracted to male, or female. So they had all these different specifiers, and those were deleted. They considered that that's not even important anymore, because it's what matters is what the person wants, right? Is what the person is feeling, actually. So the DSM-5 also separates the diagnosis for children from that of adolescents and adults, and this is one of the biggest issues, is the proposed treatments for children, and we'll go into that. I think did you guys have a lecture with Dr. Vizcarrono? Okay, so he goes over the specifics of the children. He's a pediatrician, so he goes over the specifics of the treatments and all the issues for the pediatrician patients. So you'll learn more specifics about that. But this is one of the biggest and most controversial issues at this point. And what else do we have? So the distress, therefore, does not necessarily result from the condition, but from society's unwillingness to give those with gender dysphoria the medical assistance necessary to alter their sex according to their interior sense of experienced or expressed gender. Okay, very important distinction. So if we think about the the Catholic understanding of anthropology and gender, I got most of my information from the National Catholic Bioethics Center. And actually, when I send you guys the updated slides, I'll send you the references and everything as well. They're all within the slides. What it means to be a human person, that there's body and soul unity, that these two principles.
Do you mind if I just take a picture of that?
Of course, yeah. So that these things cannot exist independent of each other. We are body and soul. A person's sex is manifested by the body in accordance to how the person was created. The soul is neither male or female. The body alone determines the sex of the person. And gender ideology proponents suggest that there can be a male soul within a female body and vice versa. And this is, you know, if you're talking about Catholic bioethics, this is completely contrary to what we propose. The spiritual powers of intellect and will have no gender. And John Paul II famously put it, the human body expresses the person. So within the theology of the body teachings, they give us a greater understanding of why these things are objective truths to us, right? So there's a wonderful article from the NCBC about, and it's a critique on gender dysphoria. And they mention all of these different subjects. So what are the ethical implications? Gender transitioning is an act against the person's own good, a fundamental rejection of self, and it's considered self-mutilation, whether it's by medical or chemical harm. It does not ultimately contribute to human flourishing. So my purpose in medicine and the reason why I went into psychiatry was to help people to flourish and to become, you know, the best person they can be. And what we propose is that these treatments, in fact, do not lead or contribute to human flourishing. And this leads to moral repercussions in the practical order, which we'll see in another slide. And lack of evidence, there's a definite lack of evidence showing medical improvements with gender transitioning. That's a big problem. There's a lack of informed consent. So going back to the principles, the patient, in my opinion, should be able to make good decisions for themselves. And there is a complete lack of consent because of the decision to go into this. I believe that doctors really don't have the research to say this is totally safe and effective. It's not safe and effective. So there is no real consent, and especially with children, if you're 9 years old, how can you make a true informed consent at 9 years old? And it is also a violation of the medical standard to do no harm. So there's many controversies within the mental health treatments. So in psychiatry, I have to take into account the medical and the psychological. And there's both treatments for gender dysphoria. The psychological treatments are the therapies, and the medical treatments are either the chemicals, or giving hormones, or puberty blockers for children, and then the surgical treatment. So this is a surgical treatment for a psychological condition. So where does that's another big concern, right? So persons claiming to be transgender must be accompanied on their difficult journey with true charity and should be offered ethical, effective therapies based on sound anthropology and scientific evidence. So what I propose is that really there is no scientific evidence that these treatments are safe and effective. So we have psychosocial, environmental causes that really have been found to bring about this condition. I guess I can't say disorder anymore, right? So it's been found that there's significant evidence for parental psychopathology. There's issues with family dynamics. There's adverse childhood events, such as sexual abuse or trauma. Social reinforcements, so being accepted, belonging to communities this is very important, especially in children and teens. And it's been found that really there's a social contagion aspect to it by mainstream media and social media. And we'll go into more recent events related to that. And there are significant controversies, and in fact, whatever therapies were available in the past that we were trying to provide have actually been banned. In New York, it's completely out. If they find someone doing conversion therapy, they can actually lose their license. So these affirming therapies, the affirming therapies are the only therapies that can be given. So there's, and within the community of psychiatric and psychological associations, these therapies are very controversial in and of themselves. They're also not super, placebo-controlled cohorts, trial. No one really has a lot of evidence. But if you wanted to have this kind of therapy, you can't. So there's parents that would want their children to have this kind of therapy, and so they're no longer available. In some places they could be, but it's been chipped away at pretty aggressively, that these treatments cannot be performed. So there's the controversy with that. And like I said, there's really no clinical data to support specific interventions. So this is a big problem. Okay. So then you have the hormonal and surgical interventions for the psychological issue. And most studies show negative outcomes, as we'll see here. I have, maybe I can find it here online. This one is connected to the internet, this laptop. What I was having trouble with before was with the audio. So maybe what I was thinking was that I could maybe do it here. I don't know if the people online can hear it.
Or if you email it to Shopee, we can access it.
From here?
If you email it from your laptop to Shopee's email, we can access that video. If you email it, link to the video.
Or I can look for it on YouTube. But then are you going to hear it from where? From here? Okay, so let's see, because I think it's like a 5-minute video, and they really touch on everything that we're, let's see, YouTube. Let's see, it's like a 5-minute, yeah, it's like a 5-minute video.
I'm Adam Kuiper. I'm the editor of The New Atlantis. It's a magazine, a quarterly journal about the social, political, ethical implications of modern science, technology, and medicine. In our most recent issue, we offer a report that deals with one of the most complex, sometimes even fraught aspects of human existence, Sexuality and Gender. The authors are Dr. Lawrence Mayer, an epidemiologist also trained as a psychiatrist, and Dr. Paul McHugh, arguably the most important figure in American psychiatry in the last half century. What we found is that there's a large gap between, on the one hand, the certainty with which beliefs are held about these matters, and on the other, what a sober assessment of the science reveals.
I think in the transgender world and the world of both heterosexual and homosexual life, the assumption that science has given us full answers and it is complete is closing off debate about what further science is needed, what the nature of the contemporary science really is.
The science isn't set.
Science is never settled, okay? That there's always another and better experiment and a better study to do. The claim that it is settled now, that the issues such as born that way, or you're fixed, or it's immutable, there is no evidence from the science that those things are correct.
What can science tell us about the health and mental health outcomes for people who identify as a gender other than their biological sex?
Well, although the data is very limited, the data that we have is quite alarming. That people who identify as transgender have higher rates of mental health problems and even higher rates of suicidal thoughts, ideation attempts than the general population. This is concern to me as an epidemiologist.
Would you say that overall in this entire field, human sexuality and gender identity, would you say that generally speaking, more research is needed for these public health questions?
I would say more scientifically based research is needed. I mean, there are thousands of articles published where people express opinions and then they grab some data to support their opinion. But the sort of long-term follow-up that looked at an entire community over time, compared it to other communities, that's what we really need.
What is it that has led you to look into this transgender question in the first place? Why do you care about these matters, and why should the rest of us?
I care about the welfare of children a great deal. That's probably my primary concern, and I got involved when I read more and more statements about the discovery that children as young as 2 years old were transgender. The parents declared they were transgender, when in fact, the majority of children who at some time in their life identify with members of the opposite sex actually grow out of that. The notion of gender among children is very, very fluid.
Do we know anything about the different kinds of treatments and their mental health outcomes when it comes to children?
No, we have very limited data because what we need is long-term follow-up data of what happens to these kids if they identify, if they're encouraged in that identification, or if they're given hormone-blocking therapies, or even if they have surgery. We really don't have long-term follow-up data. This is a vulnerable population. I want to focus on their vulnerabilities.
We are interested as psychiatrists in talking to people about what's going to make their life be as full as it can be.
So human flourishing as the aim here of the therapy.
Yeah, the aim is to make sure that people aren't finding themselves in a misdirection of their life that's going to keep them from flourishing as people.
And the idea here is a full understanding of what it means to be human.
Yes.
All right. So really what we're looking at, and from the studies that we do have, this one, YouTube kept going. Hold on a second.
When I was a doctoral student at Syracuse University.
Okay. Because we might come back to. Why is this? Okay. So this one, for example, this is a long-term follow-up study. And it's a pretty good one. It's, it does have limitations, but what was found as they followed a cohort of people was that those who had actually gone through the treatments and who had transitioned had 3 times higher risk of psychiatric hospitalizations, 3 times higher risk of all-cause mortality, so because of medical issues, because of crime, etc., an increased risk of being convicted of a crime. And they also had, and this is probably the most damning evidence, that they have a far greater risk of attempting and completing suicide than the general population. We're talking about almost 5 times higher risk of attempted suicide within this population and 19.1 times more likely to complete suicide. This isn't negligible. This is an extremely, I think he, in the Atlantis report, the doctor expressed, he used the word alarming. To us, this is an alarming rate of suicide. And, we can look at all kinds of articles, like they said, there's tons of articles, but really we don't have enough longitudinal evidence. And with the children, especially if you're giving hormone blocking medications that prevent them to go through puberty, we have no idea what that's going to happen. What's going to happen with that 30 years from now? What's their health going to be like? What challenges are they going to have? Exposure to these hormones is very damaging so you're basically causing illness. You're taking something that is functioning and you're causing a dysfunction, right? Biologically, if we're talking about the biological treatments. So a slide that I had added, and I'm going to just look at it from over here. So I wanted to go over the suicide risk factors because the proponents actually would have us believe that the higher rate of mental health issues and suicide rates are related to not the incongruent idea that I'm a male stuck in a female body, not because of that. All the psychiatric issues are because of not being able to get treatment. That's what you would propose. But really, if you look at what we know are suicide risk factors, right on top of there is mental illness. And most cases of transgender or gender dysphoria have a history of psychiatric issues as well. So that increases the suicide risk, right? So we have demographics. Usually at higher risk are males, widowed, divorced, single. The risk also increases with age, and usually white populations are at higher risk. So that really brings another question. If they're saying that we become suicidal because we are being discriminated against, well, the highest rate of suicide is actually white, older males. That's the highest rate of suicide. So if you look at the Black population who have really undergone discrimination, they don't have a higher rate of suicide, and they have a much higher rate of discrimination. So these are just things that, you know, questions that come up that I like to bring up so that you can compare and see what is being taught, what is being said to the to the masses, is that it's because of discrimination, but it's really related to mental health, and they just don't want to have it as a mental health issue. That it's, I can't get the treatment I want, that's the problem I have, okay? Psychosocial factors of suicide, lack of social support, unemployment, drop in socioeconomic status, and access to firearm, that increases your risk of suicide. Physical illnesses like like cancer or HIV/AIDS, peptic ulcer disease. So I have a list of neurologic symptoms or diseases, pain. Those are all illnesses that increase your risk for suicide. There's the psychological dimension, hopelessness, psychic pain, anxiety, agitation, psychological turmoil, decreased self-esteem, fragile narcissism, and perfectionism. So does this sound like something that would be going on with someone who wants to transition? Yes, absolutely. And this is not a physical illness. These are psychological factors. Okay, so that increases your risk for suicide. Behavioral dimensions, people that are very impulsive, aggressive, severe anxiety, panic attacks, and definitely a prior suicide attempt increases your risk of attempting or committing suicide. Cognitive dimensions, thought constriction, polarized thinking, and rigidity, and studying kids with gender dysphoria, they have found that they're really in the time prior to coming out to their parents, they're on social media, it's almost like an obsession. So it's this rigidity of thinking that this is my problem and this is my only solution. And that kind of thinking also increases your risk for suicide. The trauma, sexual, physical abuse, neglect, parental loss, traumatic events, all of these are risk for gender dysphoria, also risk for suicide. And genetic and familial, so if there's a family history of suicide and mental illness, that also increases your risk. So.
Question. Like, you know, a lot of people will argue that the high risk of suicide is because of them not being accepted by society and like being bullied and pushed away. What do you say about that?
There's some reality to it because it is a societal issue, right? But to separate mental illness from gender dysphoria is a very big risk, in my opinion, because of that. So they have a higher risk of suicidality because of mental illness. But it's not considered mental, you can't say it's mental illness. So these are, very touchy subjects. So in my opinion, yes, it's from within and from without, but mostly from within. Because most of society, I think you could say now, is totally accepting of it, right? It's totally, it's like you do whatever you want. If you think you're a girl, then you're fine. Do whatever you want. So we're essentially accepting it. We're proposing treatments. We're putting people through surgeries. We're doing double mastectomies for 13-year-olds, but they still commit suicide. So the answer is nebulous, but it's pretty straightforward. If we're following the data, if we're following the evidence, we have to accept that it is not because society doesn't accept it, because they do now.
That means that someone's 13-year-old's parents agree with them to still do that.
Yes. So the parents are providing informed consent because a child can't provide informed consent. They don't know what it's really, yeah, it's very tricky. And even worse is that we don't have the evidence that that's going to make them happy, and it doesn't. The evidence says that they still commit suicide, even after going through this transition.
So from a Christian anthropology point of view, on a Catholic bioethics approach, we can consider this gender issues a disorder, a mental disorder?
Yes.
Okay, do we have enough data to prove that if it's approached as a disorder and treated as such, what are the outcomes?
We don't have the data.
So we don't have here, we don't have there.
We don't have, right.
How can we then say that the other side of the coin is wrong?
In fact, the other side of the coin has evidence that it's not good.
But we don't have evidence that is good.
No, we have case reports. We have, like Dr. Fitzgibbons has done studies. Nicholas, he's in one of the other videos. We have therapists that have, they've studied it because they've been treating it with the Christian understanding of the human person, but it's not sufficient data. And certainly the people that put together the Diagnostic and Statistical Manual have, in fact, ignored anything that there is a section of the APA, of the American Psychiatric Association, that is still holding on, trying to fight back. But I mean, the publications are suppressed. They're very, no one is accepting it. We want to accept that it is good. We want to accept that it's good, a good treatment to put someone through transition treatment because they're going to be happier.
So you mentioned that in New York, it's totally banned.
And I think New Jersey.
What is the name of that treatment?
Conversion therapy.
Okay. So it's only New York. For the rest of the country, is it still available for
I
people?
think California and here last year it was being debated.
I'm sorry, I didn't get that.
Conversion therapy is helping someone go through the transition.
No.
Right,
It's
conversion
the
therapy is
opposite,
like
right?
sending them to daycare, so they're not gaining. That's what I thought.
Yeah. So any therapies that are not affirming what the person wants have been banned. So, or are in the process of being banned. Now, I don't agree with conversion therapy, as a matter of fact, because it's, I don't think it's the right approach, but that's just, it's not the right approach. And usually it's parents bringing the kids. And if a parent brings me a kid and the kid tells me, listen, I'm lesbian, there's nothing they can do about it. There's nothing I can do about it. I am not going to try to make that child change their mind. I can give them information so that they can have an informed consent. And I can tell them, listen, if you have same-sex attraction, or if you're feeling like you're in the wrong, that you were assigned the wrong sex, here's the evidence saying that this is actually not good for you, versus evidence saying that it is. And there is evidence, that, oh, they're so happy, and once they go through the transition, but it's not longitudinal data. It's just what they say in the moment. So if you ask them in the moment, it may be kind of like with abortion, when the first studies started coming out, that they were like, oh, I'm so relieved I did it. This is the best decision of my life. Ask them 10 years from now. It's a different story. Yeah. So conversion therapy there's another one, reparative therapy. They do have their own data. So they've collected data, and some places have their case reports and their information, but it's not widely accepted in any way, shape, or form. And in fact, you know, I still believe that something should be available, because if someone does not want, if it's same-sex attraction or any of these issues that is unwanted, there should be treatment for those who feel like it's ego dystonic, like it's not of them, like they don't want to live like that, right? But then they're limiting us because I want to provide it, but, you know, or at least support the person in living a chaste life if that's what they want, right? If that's what they want, they should be able to have something available. So, but that's very controversial, yeah. So we're not able to do it, but, and actually, then I was saying before, last year around this time, yeah, it was being debated in Broward and Dade County that they were doing, trying to ban these kinds of therapies for children. So it's for children that it's banned for, like that you can't, parents can't make their children go through that. So lots of controversies here. And I also wanted to mention, which is not in the old slides, an article came out recently, and this has been all over, it's a big debate. Someone came out with a study about what's now called rapid onset gender dysphoria in adolescents and young adults. And it was a study of parental reports. So what they did was the researcher went to a website and asked parents to volunteer information. And because child and adolescent psychiatrists are seeing this so much, it's kind of a phenomenon that's going on. So the study kind of put it in the context of social contagion, and that mostly, like a very large proportion of the kids that are coming in saying that that they have gender dysphoria actually all had kind of the same story, which was teenage girls, and they were a part of a group. So it would almost be like 4 girls that all of a sudden one of them comes up with the idea that she's gender dysphoric and she wants to transition and she wants to become male. And then their group of friends start coming out with the same condition, right? So the backlash to this study was such that they actually, I don't know if they formally retracted, but it has been extremely controversial. This exploded just like maybe like a month ago or so. It was 2018. And with the slides that I'll send Father Shofi, you'll have the reference there so you can read it. And it was really telling. To me, it's just more information on how off the rails we've gone, right? So up to 95% of kids who say they're gender dysphoric actually grow out of it. So, and that is fact. That's a fact, that it's gender fluid, fluidity, like from when you're 2 years old, you can't possibly decide what your gender is. So, and one of the slides that I wanted to show you from that article was what the kids were reading online. They made a slide. Just listen to this. Instructions online. Find out what they want to hear. This is, so a kid is reading this. Your child is reading this online. If you want to, that they want to hear, if they're going to give you T, which is testosterone, and then tell them just that. So tell them what they want to hear. It's about getting treatment, not about being true to those around you. It's not their business. And a lot of time, doctors will screw stuff up for you. So what to tell the doctor so that the doctor doesn't say, oh no, honey, you don't really need this. No, this is what you're going to say.
But where do they get that?
Online.
Well, who published that?
So these are the study that came out saying that it's a social contagion. That was super controversial. They put this is one of their slides because they asked parents to tell them, what is it that is going on with your child? And most of them were teenage girls or like young girls, that it was within a group of friends. They gave the example that one of them was that the coach that they were very close with came out as transgender. And then one by one, the girls started coming out as transgender as well. And so, they spend a lot of time on social media and online. And these are the things that the parents showed the researchers, like this is what they're reading online. So,
yeah, that's what I was wondering, like, who posts those instructions for kids to read online? Like, that's...
Right. This is peer-to-peer probably. So it's kids telling other kids. Get a story ready in your head. And as suggested, keep the lie to a minimum. And only for stuff that can't be verified, like how you were feeling, but were too afraid to tell anyone, including your family. I'd also look up the DSM for the diagnostic criteria for transgender and make sure your story fits it, assuming your psych follows it, your psychiatrist follows it. So giving you instructions on what to say, where to look for the criteria so that you can go to the doctor and say, I'm transgender and this is why I need treatment. I need hormones, I need the treatments. Mm-hmm.
How are these kids able to talk to the doctor without any consent from the parent?
They do have consent from the parent.
In Florida? Is this happening here?
Oh, yeah. Yeah.
So then why do parents have to sign for other kids? I mean, why doesn't a kid just live on its own and provide for itself and govern that decision?
Right. You'll find that none of this makes sense.
I know the world is all but this is like
the parents encourage it a lot of the times, and that's something that came up from the critiques about the article, whether pro or for it or against it. Some of the things that have come up have been that it's almost like, I think one of the parents described it here, that it was almost like a gold star, that if your child comes out as transgender, then they're no longer bullied, they're treated super specially, they become very popular with their friends. It's like a gold star. It's like, and the parents support it because it's like, oh my God, she's, this is it, this is the problem. And they go down that route. Mm-hmm.
I can't help but think of a little bit of a parallel with kids trying to get on, like, let's say Adderall, or going, and then they have their special case, right? Mm-hmm. They have the
special accommodations.
Yeah, they spend time. And I've even heard kids in my classes last year, like 15, 16, saying, "I got Addie's." Like they know what they're doing. They're trying to seek certain.
Yeah, my students, they're finding out that, she took the class or whatever.
They're happy about it.
Yeah, and then like the whole class.
Yeah. So with this specifically, it's that they become like super special. And the parents, remember, the number one thing on the list of why this even occurs is parental pathology. So it almost is like also a coercion on the parents' part. Like, okay, if this is what you want, then this is what, and then they push for the treatment. So they're the one giving the consent, but they're severely misinformed. severely misinformed. Like, this is not a true informed consent, because they don't know the consequences. They don't even know if the child is just, for lack of a better word, going through a phase, which research shows it really looks like they are. So it's just, it's really remarkable, very remarkable how psychiatry has just gone hook, line, and sinker for this whole thing. And it's once it's on the DSM, that's it. That's it. And it's not a disorder. So
that actually happened with they tried to develop pedophilia in 2013 in order to the DSM. And it was like a movement, you know?
yeah,
Like it cannot
to normalize it. Mm-hmm.
and
Absolutely.
trying. But I remember in 2013,
They're going to keep
like,
trying. So it's,
A couple years.
so we're even if you thought 10 years ago, we wouldn't be talking about this. You know, it's just very rapidly progressing into others. So really, since we're talking about from the Catholic bioethic perspective, you know, it's really the turning away from truth, turning away from the.
When you remove God, all of this madness.
And just moral theology, you know, you're turning away from the truth of, okay, this is a male. It's not like at the very beginning, we were mentioning that it's not ambiguous genitalia. It's not someone with a genetic disorder. It's not someone with a hormonal disorder. It's someone who is literally XY, and phenotype is expressing XY, but psychologically they've come to believe that. So if you reject the truth of what the body is saying, then we can do whatever we want. I can say I'm a, you know, I don't know, a Barbie doll, a dog. You can, where do we go from here?
People better accept your dog.
And you better call me, like, yeah, and it's
Intervention of people, person thinks that they're a piece of furniture.
or, oh, and another one that's really very remarkable that's also getting some footing is people who think they should be amputated, like, you know, I want to be an amputee, and then you have doctors that actually just go ahead and do it. So they amputate their legs or arms because they feel like I'm an amputee.
How are professionals like giving into this? It's like
That's crazy.
Money
like,
ties.
what's behind all of this, really? And
Where are we going? Where are we going? Where's this leading to? What's the end game? Is always my question. What is the end game? So,
it's really a spiritual war.
mhm.
Well, to find out where you're
Relativism.
going, you have to be able to follow a path. And if you don't know the path, you really don't know where you're going.
Mhm.
And that's the issue I believe within society. We don't have a path.
Mhm. So it's relativism.
Yes, there's nothing, there's no model.
Right.
We
To
use
follow.
ourselves as models. And I guess, you know, this is total imperfection here, but that's the model. And so we go in that trend.
Yeah. And the relativistic view that you can do whatever you want and no one can tell me what I can or can't do.
Well,
So if I say that this is what I want to do, then no one can tell me otherwise. So it's, you know, relativism and just a total rejection of truth.
one of the issues out here earlier in one of your slides, you show that there were 3 different designations or they treat the child, the young adolescent, and the adult. But if you even look at the issue of abortion, some states, for instance, the child does not need any permission. So how soon do we go down that far into that slippery slope where a child doesn't need parental permission to have
Reassignment surgery. Yeah. That's where we're going. That's where we're headed. That we're letting kids make these decisions that really, again, going back to the principles, it's not informed consent. They don't have the capacity to make these decisions. It is not within their capacity for a child to make a lifelong decision like this, especially medically, not having the evidence that says, if you do this, it is safe and effective. Because it's not safe for so many reasons, and it is not effective because that's what the studies really show, that they end up in a psych hospital anyway. They end up still requiring psychiatric treatment because you're not addressing the underlying issue, which is completely psychological, which is addressed in therapy.
I think the doctor will mention that kids tend to identify maybe with the girls the first time or with boys or whatever, and then, you know, how kids are, then they want to wear chains and it's phases.
They go through the goth phase,
Right.
and yeah, and they grow out of it. They really do. Kind of, and that's something that was found mentioned in this study of rapid onset as well, that the kids themselves, and this is the parents reporting, the kids themselves asked to be removed from that school, or to be, so people would move their families, and then the child would get better because it was the group. It was literally a social contagion. So they went on and it was like, I need to get away from this group because this is toxic. Like a kid could recognize that. And then they would move them away, and then they would be completely normal and go on with their lives. So this study was, I mean, I'm suspecting they're going to have the pressure to retract it, but it's out there. And what's good news to me is that when I read the comments, whether it's doctors, psychiatrists, social workers, people who just comment on it, they are very aware that, well, this is what the evidence is showing, and we cannot permit it to be pressured into ignoring what the evidence is showing. We have to go where the science leads us. We can't just be pressured into thinking a certain way and ignore the evidence. So that's refreshing. That's sort of good news, because, you know, the comments really, like, people haven't completely lost touch with the fact that we're ignoring science. So that's good. So we talked about suicide. Here's Dr. Hugh McHugh from Hopkins. And he was the chief psychiatrist for 25 years. He has more than 40 years experience working with gender issues. And this is his quote. I believe this was from LifeSite. LifeSite News. That we're doing experiments on these children. We should tell everybody this is an experimental procedure right now. And that experiment is not being done with controls. It's not being done with clear statements to the parents that we can't tell them what the outcome's going to be. So again, the issue of true consent, an average age of treatment starts at 9 years old. So a very large number of these families are going to find that they've been misled or misdirected. So this is from the chief of psychiatry of Johns Hopkins. And in fact, I think at Hopkins, they stopped doing the surgeries. Yeah. They stopped them. Other centers are flourishing because of it. So, but with them, they decided that it wasn't a good idea. So this is just kind of, when I was looking for case studies, this is one that I found from the psychiatric community, and it really gives us an idea, right? It's that person that is an adult that is wanting to go through the legal process of changing from male to female. He started seeing himself as Christine. He had been born with male genitals and was raised as a boy. Nothing unusual was noted by his parents until childhood, at which point Christopher was viewed as a sissy by other children. Christopher sought out female friends in school and chose activities and clubs that mainly involved girls. And this description really fits the DSM-4 description of gender identity disorder. So really being attracted to the opposite sex activities and even dressing, etc. He felt he was Christine instead of Christopher. Christopher did well in college and became very fond of a longtime friend. Although he did not feel sexually drawn to her, he wanted very much to please his father. So he married, and after college, he married her after college. He was fairly content with his married life, but he knew he was living mostly to please his family. He felt much more at ease when he could think of himself as Christine. When his wife was not at home, he would often wear her clothing. Over years of marriage, he felt more unhappy, upset with himself, that he was not being honest with his own life goals or honest with his wife and family. He sought treatment from a mental health care provider. After he talked about his life at length, he began to talk about his sense that he is Christine and his fears of letting down his family. As Christine, he began to share more private feelings in therapy. He became more secure in describing himself as a woman and began to ask some of his closest friends to refer to him as she. Over time, she, Christine, began to realize that she was not going to have the quality of life she wanted unless she began to live openly as a woman. Over the next several months, she worked with her mental health care provider to gain courage to tell her wife what she wants to separate. She also sought a referral for a specialist who would inform her about hormone treatments and surgeries. She might someday explore these options if she wanted to change her physical appearance to female, but she knew this would be a big decision. The first step would be to learn how to discuss her condition with all of her family and friends and decide how to begin changing her life to match the female role. She sought out a specialist who works with people who have gender dysphoria to help with the process. As she knew, it would be a very hard transition for her wife. Christine's father also would have trouble accepting the diagnosis and why it was crucial to Christine to be able to live her life as a woman. So this is, I was looking for case reports so we could discuss, and this is the best I found, right? So it shows you how mental health providers are involved in affirming, kind of bringing it out of the person, affirming it, and then helping almost coach you through how you're going to put your family through this, and then do the referrals for the actual medical treatments. And it can be argued that the screening that goes into this, mental health issues are being very widely ignored. If the person is depressed, if the person is anxious, if there's a past history of suicide attempts, all of that goes into the decision making, but always affirming that, okay, so then obviously then what you need is a gender reassignment. So this is what, for example, a psychiatric resident, someone studying psychiatry, would study a case like this. But so my issue with this is what happened afterwards. So what was the outcome? I don't know what happened. Did it go okay? Did he live happily ever after? So that's what later we find, that then they continue to have mental health problems. It doesn't, just going through the treatments doesn't take care of the issue.
I once saw a video of a guy who did the surgery years ago, and he would write everything.
Mm-hmm.
He was suicidal. I'll have to find that video. I posted it on my Facebook.
Yeah.
He was like trying to like let people know who are having issues. That's not the way. And he's like, I wish people would hold me around me, but everybody was supportive. So he didn't know, but
Yeah.
like found God along the way. But I mean, he went through a lot. He was an older man. You know,
And I saw,
he cried and everything from how terrible the effects of it.
yeah, and medically as well. I saw a case of someone in, I think it was in, I don't know if it was Ireland or England probably, that he, as a teen, we're talking like maybe 15 years old, decided, no, I'm a woman. So everyone supported, you know, and okay, let's go through this whole thing, went through sex reassignment, found himself suicidal, continued mental health issues, then said, okay, then maybe I should go back. So then goes back to identifying as male, completely goes in a spiral and is still psychiatrically ill, and so says, you know what, I'm just going to go back to being a woman because that's what I should be. And then so it's very unstable. And what is everything that I am saying here is very controversial in the psychological, you know, like I'm being completely opposite of what they propose and what they're saying, but I'm not ignoring the evidence. The evidence clearly, you know, shows that for the most part, people are not happy. This is not something that's going to, like they said, you know, help someone flourish. So, and but unfortunately, you know, this is where we are, and I don't know where it's going. I mentioned when I gave this lecture before that if I've never actually had someone come to me for therapy affirming this, or trying to, or do the clearance, psychiatric clearance to go through the surgery. I've never had to do any of that, but that would really put me, number one, I would be suspicious, because, you know, if you go to my website, it's clearly Christian. I mean, my practice is St. Raphael Behavioral Health. You know, if you're coming to me for that kind of thing, I would be suspicious that they're trying to, you know, get me to say no so that they can sue me. So yeah, so I have to be careful, and I don't reject patients for any reason, but I do have to disclose, listen, I think this is contrary to what is good for you. So back to the principles that I have the duty to do no harm, and in my opinion, this causes harm. But I'm fighting against their autonomy. So they have the right to decide what's right for themselves, but that's contradicting my belief that really it's medically not an appropriate treatment. So other issues, the business aspect of it. This is a business. This is a big, big business. There's centers coming up where you can get all the treatments, and so children they're given hormones from a very early age, and it's almost like you can't stop this. But from my perspective, you know, it's just going to be one person at a time.
I thought this issue was still like pretty new, so I didn't know, like, that's it, like children are already
they're getting hormone blockers so that they don't go through puberty, and they're afraid of going through puberty. So once the boys' voice start changing, they start getting facial hair, etc. Once breasts start growing for girls, you know, and then it increases their psychological stress.
That's crazy.
The parents are also a part of society now.
Yeah.
You have to be there for your child. You have to, or you know, encourage them to be themselves. That's everything that society is teaching us right now.
Mm-hmm. I'm going to show you another video that kind of that mentions so since I couldn't find case studies that really clinically told us what's going on, I found this. Wait, the one I specifically want to see. Okay, maybe if I spell it like they have it. Well, I can't find the specific one because I like that it has specific. Let's just see this one because it has like some key issues mentioned. Let's see what this one. I've actually never, I don't know what trailer is going to come up.
I trade at bookstores all the time, and I saw this one magazine, and it said transformation. The top half, they have the boobs and the penis on the bottom, and you know, and I thought, oh, this is cool, this is different.
I would go to these places where my dad lived. He would have full-on sex with me, and he would say things that made me feel like I was a woman.
It would be better to be a boy. People are recognizing that I'm already cute as a boy, so I might as well be that. And being a woman isn't really a great option.
In 45 minutes, he looked at me and he says, you've got gender dysphoria. What you need to do is undergo gender reassignment surgery, take hormones. This is a lie that is being promoted by an incredible industry that's making a lot of money on these poor people.
I really wanted to have a sex change because I felt it would complete me.
Well, the best part is I got all dolled up. I feel like a girl, and I can actually get put on the makeup and do the hair and wear women's clothes.
By the time I was 42 years old, I sat down with my wife and said, here's what's been happening. We need to divorce and I need to change genders.
She threw her head up and she looked at me and she opened her legs and she said, this is all one. Male genitalia was there. I couldn't believe that this was true. And I knew that it was possible.
By the time I was 18, I began competing in professional pageantry. And by the age of 19, I was competing at the Miss Gay Texas pageant.
So I took the hormones, of course, right away, I started filling out muscularly. I started getting acne, and I started growing beard.
I saved up my money, went to Thailand, halfway across the world, got surgery. I had breast implants. I was living my life as a woman.
That's when I was introduced to the black market of plastic surgery.
I woke up from the operation, and I got these big boobs and vagina, the whole thing, tubes hanging out here and there, and it's like, wow, what have I done?
It's not about being feminine, it's about being holy.
So it's a documentary, and it goes through these people's experiences, etc. It is from a Christian point of view, and the other trailer that I had, I really liked the ending because someone did mention God and how he came to understand the reality of, and of God's love, and really that's what led to healing, etc. So it is very, I mean, when I look at the one I have here, it only has like 20,000 views. So this is very socially not accepted it is not accepted that we should say any of the things that I've said here. But, you know, that's all we can do, is to continue to stand our ground and for objective truth. Okay. So any questions regarding this particular issue? I know you guys have until like 12. So if you wanted to go like a Q&A about other mental health issues, we could do that too. We could take a break, whatever you guys want to do. Let me close this out. So we had the case study, and then, yeah, and that was it. Because Father is going to discuss physician-assisted suicide and euthanasia with you guys at another time. And any questions from the people online? Yeah. So if there's no questions, then that's going to be it for today. And I'll give you guys the slides of so that you can see the reference for the rapid onset gender dysphoria study that's highly contentious that they wanted to actually suppress. So
well, earlier you mentioned that they're putting more money, and these, let's say, clinics are starting up all over the place. So this is going to become a brand new industry altogether.
It is. It already is.
So we haven't really seen it as yet. Like, I mean, abortion, I think it has peaked. The industry itself, in a sense, has peaked. Money-wise, as a dollar number. But this is new on the horizon.
The tip of the iceberg, yeah. Especially with kids, because it's targeted very, I would say, I don't know if it's malicious or not, it's malicious intent. I mean, I would like to believe that the medical community really, truly believes that it is a good and that they're doing a service. But that remains to be seen.
See, there's another part that they're playing on that we have not looked at, is that kids tend to be much more curious than adults are.
Yeah.
And a lot of their feelings, if you will, are led by curiosity. And that's also the sense of adventure. And these clinics are going to be preying, P-R-E-Y, on this, on those weaknesses, you know.
And it's a part of development. It's actually a part of development to look for your identity. So that's that's what teenagers are going through. That's why they're so, like, they seem unstable, and they're just, because they're trying to find out who they are. Yeah. And then, but now we have added another layer that is like, okay, so now you can also decide whether you really are the gender that you were, quote unquote, assigned. So it adds to, in my opinion, it adds to the confusion that is being a teenager, right? It's all confusion, but now it adds another layer.
As you know, as a psychiatrist, the toughest transition of just about any human being is that puberty to your young adolescent. That is probably the roughest transition of your growth, of your maturity, physically as well as mentally. So, and they go be preying on that. This is crazy.
Yeah, and the suicide risk for teenagers is very high.
Yeah.
So adding this to it really increases the risk of suicidal behaviors, suicidal thoughts, suicidal actions.
We need more Catholic schools.
And we need them to teach Catholic.
I agree.
Catholic understanding.
Private school for a couple of years. I was like, what is going on? And I think my public school kids were more Christian.
Yes.
And I don't know, like I could really talk. I don't know. I did really talk, but just these kids just don't know anything. They're like, when I would teaching things, like, I would just say everything.
Yeah, we're to the point that everything that we understand is right and true, and really the treasure of the theology of the body which is really like 100% true, that there's so many levels of truth to it that you just keep, the more you dig, the more you find the reality of what it is to be a human person. And we have that treasure, it's just that we haven't been able to transmit it almost. Like I speak with my nieces and nephews, and they have been completely indoctrinated. And also, you know, on a personal note, I can say that I myself grew up in the culture of death and indoctrinated in the culture of death. And even after my psychiatric training, while I was in psychiatric training, was when I had a conversion. So we're talking, I was in my late 20s already. So I had lived my life really, truly believing that homosexuality was completely normal, that abortion and contraception was totally okay. All of these things. I was definitely indoctrinated into that thinking, and you could see how psychiatric training completely enforces that and really drives it in. There were, in my board exams, there were questions about abortion, questions about homosexuality and how you would handle it. So it's very much an indoctrination, the total opposite. So I think that's why I can really see and understand the differences, and I can see that the children are being indoctrinated into this kind of thinking. And it is very hard to have a conversation about the theology of the body in 5 minutes. You know, you can't convince someone why I think this is not okay, you know, in 5 minutes. Because it's all about feelings, right? Mm-hmm.
I walked out for a moment, but like this is like the case in Belgium, I think it was, where there's like a young lady who decided I was supposed to die. I want to die. And she went through the steps and got medical treatment to this, you know, to kill herself.
Yeah. So psychiatric illnesses.
Yeah.
In some places, psychiatric illnesses are no longer a rule out for assisted suicide. Yeah. So as a psychiatrist, I'm trying to prevent people from killing themselves. And there are places that are now saying, okay, and it used to be one of the measures. It used to be like, okay, if you have a psychiatric illness, you do not have the capacity. If you're depressed, you do not have the capacity to make that decision. So it's not competent or incompetent, it's the capacity. And that takes you off the list. But that's off the table now. In some places, it's like, it's intractable. There's no treatment, there's no electroconvulsive therapy, there's no, you know, transcranial stimulation, there's no medication, there's no antipsychotic, no antidepressant, anti-anxiety agent that can help. I want to die, and not only I want to die, I want you to do it for me. So that's where we're at.
That's kind of like with doctors, you're supposed to save lives.
Exactly.
You take an oath, like,
Yeah.
To do no harm.
Do no harm.
Do no harm.
like my husband's a physician, and like the things I'm like, certain things, like I hear stories, I'm like, God, I wish you could just say something else, but like they're trained, which is like messed up to say, you know, you can't really speak the truth, but you're there to really help this person. Right. A lady who's been doing it.
Yeah, you know, you have to find your way, because, and especially in psychiatry, there's all these ethical issues that, you know, like I mentioned, I've had many parents try to bring me their kids, and I'm like, sorry, I can't, you know. So far, I had one girl that actually listened. She was extremely, like, a brilliant 13-year-old, and she was convinced that she was a lesbian, but I was able to talk to her about, I gave her the information so that she could make the decision for herself. So
could you take us through that? How
what I spoke to her about, so I pointed out that from what she was expressing, she was identifying herself by her sexuality. And we are not only our sexuality. So she was saying, I'm a lesbian and that's it, but I'm a Catholic, so now I can't belong. And, you know, she was very conflicted with that. And it was very painful for her because she was saying, they don't accept me. And I was like, but you're so-and-so. You are not just what you're identifying as your sexual orientation. And in those conversations, you know, within the context of therapy, she was able to come to, once she would go home and start thinking about it and listening to her friends and what her friends were saying and what she was feeling within herself and within the reality of her life, she was like, yeah, this doesn't define me. She said it. She was the one that came back and said, this is silly. This does not define me. This is not who I am.
What influenced her in her life to think that?
Her friends.
Her friends.
Yeah. So she was, you know, in a group of friends that they started.
So did she have to break friendship with them? She had to separate from that group?
For that girl, I don't know, because once we got to that place and she was no longer depressed and anxious, and I didn't even have to give her medication or anything, then treatment was completed. So I think I didn't continue treatment with her, but it was very much the influence of her friends, and she was able to see that. She was, you know, I was able to give her information so that she could see for herself that she was almost labeling herself as opposed to just being herself, which is, you know, a beloved daughter of God, not just this one stamp of identity. Yeah.
Yeah, I think your husband, Dr. Rodriguez was saying earlier, like you give information. I wonder, did she no longer?
From last I heard, she was like, no, in her case, she found it to be, she was able to reason that she was just identifying herself like, as if it was like a goth group, that kind of thing, that it was more like peer pressure. And so she was able to see that for herself. Mm-hmm.
A question I have for like that particular case, could it have been other factors too? Like she had, this is when I think of like people that know, maybe like she had issues at home, maybe she had low self-esteem.
All of it.
Been overweight. Boys are not really into her.
Yeah. Very, like, I think this girl was like genius level too. And in a new environment, new school, she was super smart and quick, and very, she had a strong character and so difficult to get along with others. It was difficult for her to get along with others, almost a little intimidating. So I think she found a niche with this group of girls, but then went down that rabbit hole of like sexual orientation and da-da-da. And in my opinion, you know, very much influenced by friends and social media and then the attention that you get from that kind of behavior at that age, right? So for older people and for adults, it's a little different. And obviously someone who has the feelings from a very young age, it may be different. So this particular case was more kind of like the social contagion, like with the transgender kids.
I could see that too in high school. It happens to other who, you know, it was like in for a little bit.
Yeah.
And it's very unfortunate, but then people just push on our guys like that.
Yeah. And people identify you. They identify you. It's like, this is who you are. So she was able to see that people were identifying her. And so then she started believing it. And then once she was able to see that, like, wait a minute, this isn't, what? So that was just one case where it was a good outcome because she was no longer depressed and anxious. So that's the goal. My goal isn't to change people's minds. My goal is what's best for you. And in that case, she was okay. Another case, it was from the get-go. She was like, this is who I am. This is what I am. This is it. And then it was the struggle to help the family, you know, and the family trying to make me do something to cure her. And it's like, this is not something that I can do. This is what we have to do is bring harmony to the family. How are you going to deal with this? How are you going to, you know, love and accept your child? No, you can't. You can't. It's contrary to, and in fact, then I really get into an ethical issue because it's that I'm forcing my beliefs on this person. If they do not want it, I cannot impose it. And I don't want to even go near it. In fact, I have gay, lesbian, bisexual, you know, patients, and that's not the focus of our treatment at all. My focus is, I'm going to help you with your depression and your anxiety and your panic and whatever issues, you know, you're having at school, work, family, relationships, you know, but I can't address that. If what?
If they would want to change like their mentality, because there's been like people who have written books.
Yeah.
Like I just recently came across a video that a guy wrote from queer to Christ, and then somebody else who was just a secular guy wrote a long time ago like becoming straight. So would you help somebody in that case?
I would, if they're asking for Christian counseling, then I would help them to lead a chaste life. The same-sex attraction is something that's there probably because of trauma or because of lived experiences, or even, I mean, I've seen people that just, since they were very, very young, they just felt like they were not attracted to the opposite sex. So it's there, but if it's not something that you want to live out, then the way we can truly help is to help lead a chaste life, because we're all called to that. So we're all called to chastity. So if you're going to be a single person because you want to follow Christ, then you lead a chaste life, and then you need support in that, and you know, and how to express it, how to live it, and that can be a totally healthy person. That can truly be a totally healthy, happy person in their identity as a child of God.
So
you know,
how that same-sex attraction could be explained in the light of Catholicism?
what do you mean?
Yes, we Catholics consider it a mental disorder.
It's disordered behaviors, disordered desires. Because the ordered the order for sexuality is ordered towards marriage and, you know, sex with opposite sex, ordered towards the family and towards, so procreation and for the union of the husband and wife. So anything outside of that is considered disordered, right?
And of course, Pope Francis just said a couple years back, who am I as a judge?
We're in perilous times.
Well, I don't think you're judging though.
Exactly. It's not a judgment.
It's not judgment.
I don't think the point is to judge. On the contrary, we have to accept them, but there has to be how do I say it?
The support of the behavior.
No, we're not supporting their behavior. We're accepting them as they are, they feel they are, but it has to be clear what the Catholic Church teaches about that this order that she was mentioning, and what you have to do in that case is to press it and leave a chaste flag. Now, I know where Henry was coming from asking that question, because it's we've had friends that told us about this, and especially one of them, the case I just mentioned, that since he was very, very little, he felt that he was not a man. He was attracted to other men.
You can't explain it.
And
he said,
he
do you
cannot
think I want to feel like this? I don't want to feel like this. It cost me a lot. But my family, with friends, to be accepted too. So
there's
he
no
still
doubt.
doesn't understand why.
What
Do we
made
have
him
an
that way?
explanation to that? Not a theological explanation, but a scientific explanation of why certain people feel the same-sex attraction. Well, we Catholics, Christians call desire disorder.
Desire. Yeah.
I don't think there's a scientific explanation.
No, because it's psychosocial, biological. Like it has so many different environmental causes. Like exactly.
I mean, it's
Both.
It's
Nature, nurture.
complicated because we as Catholics can explain, the plan of God for the family and for sexuality, etc., and how, fortunately, that's your cross and you have to carry it. But I know a lot of people they want to go beyond that. Like, what you're telling me is not enough. Give me scientific reasoning, behind it, and that's why.
But also, there's no scientific evidence that it is a genetic, that it is an actual medical condition or whatever you want to call it. So there's no genetic, right? From the environment, and there could also be hormonal. There's theories that link the amount of contraception that's being consumed and wasted.
Correct.
And when it comes out, it's just like when it came in, because it's hormones, it's not broken down. And then, so there's more estrogen in it. So there's all these theories, but no one can really truly say what the cause is. And when it comes down to it, really, and it's very controversial and no one wants to hear it, no one wants to say it, but very trauma related. Like childhood experiences of same-sex, and hey, we're seeing that within our church.
There's a doctor, I think Janet Smith.
Yes.
She focuses on working with people, and she explains that 80% of them have been sexually abused. And the problem stems from the relationship with their same-sex parent. And she has worked with many where they have changed. Because she dissected the problem.
Also, the attraction in of itself is not the same. The act that is the
Right,
same.
it's a living out the
So when you
lifestyle.
speak of acceptance, it's easy to accept that the attraction itself is not the same.
Exactly.
It's the act that constitutes the same.
And I think that was Pope Francis' lack of an explanation to
that's normal.
very common on him, but he because everybody in the media, especially, you turn the "who am I to judge" phrase as he's.
It's
the
good.
Pandora box, because everybody starts coming up with their own analysis and conclusion.
Correct.
So confusion.
Well, the church doesn't judge gay people.
No.
As a matter of fact, anyone doesn't judge gay people or women that have had an abortion or. The problem is not like the deacon was saying.
It's not the sin,
it's
but
not
the sin.
It is the sin
Our
itself.
church says that
This
And
is
the
acting upon that
consequences.
urge,
And the
which is the same
consequences.
type of
It's the same.
that heterosexual person
Yes, it's the same thing.
participating in sex outside of marriage.
That's why it's disordered. So it's not ordered towards the good. So or someone who has sex addiction is just as bad. It's a, you know, or whatever, someone who is a kleptomaniac that has the compulsion to steal. Like, these things are disordered desires that we can, you know.
That doesn't make him a thief.
Unless he does it. Exactly.
Yeah,
So,
exactly.
and it's not that, yeah, no, we're not judging, but we're saying that
But I think
this is the reality. We're dealing with reality. And the reality is that you cannot separate the sexual act from its meaning and purpose and intent.
Correct.
So, but how difficult, I mean, I'm telling you, I try to talk to my nieces, nephews, and they're just like, they're completely closed to that idea. But we have to keep chipping away at it and being like, listen, we're going to stand by this because it's the truth for your body, soul, spirit in this world and the next. And maybe that's the problem, that we don't believe in the afterlife anymore, that they're not striving to reach any attainment of
I don't
heaven.
think the issue, I don't think that's the issue, not believing in the afterlife. Yeah, I think the issue is that either we don't think about it or we cannot comprehend it. It's beyond reason. It's afterlife.
Or presume too much of God's mercy.
Exactly.
Yeah.
So it's
That's
not
a great point, because I've known very good Catholics that are living their life and they're doing things that,
And they're full Psychosocial.
and they just
Love
always say,
and do whatever.
yeah, and it's like, because God is so merciful. Yes, He is merciful, but He's just.
Right. So if we have the knowledge and we choose to go against it, then we're in trouble.
Yeah,
so
You're judged.
yes, much will be expected.
The more you know, the worse it is.
Exactly. So, but a lot of people are innocent.
Ignorance is not
Like God will have mercy on some people who are never
Absolutely.
introduced to Jesus.
Right. Because some people really are innocent because so if I'm talking about myself and the way I was brought up and the way that I had a worldview that was like, everything is okay, very relativistic, everyone do whatever you want and don't tell me what to do. But would have I been condemned because that's what I was taught, right? But once I start looking into this Christianity, Catholicism thing and start learning all these things, I literally had a conversion of like everything from,
It's like the blind.
it's like, yes.
And now, like, you have, like, it's crazy. It happened to me.
Yeah.
I read.
So you understand these things and you see how so many people are ignorant, and it's not that they're willfully ignorant. It's that this is just that this is the reality we're living in, that this is what's being taught and what's being supported, all the research goes towards supporting and affirming all of these things that are contrary to the reality of the human person.
Well, as Aquinas says, we can only witness from our own experience.
Mm-hmm.
And if you're brought up in that environment, you know nothing but that environment.
Exactly.
You have your transformation, if you will, when a whole new view was opened up to you.
Mm-hmm.
That becomes your experience also.
Exactly.
That's what you live.
Exactly.
So.
And then it's connecting the dots of like, why not this? Oh, because of this, because of this. So all the way from conception to death, all of these issues that are now completely contrary to public opinion. So we're at the point where everything is, upside down, and like Catholic view is very not popular, I guess you could say. countercultural. But, you know, the good news is we do have, you know, people like the Catholic Medical Association that they're having their annual conference right now, actually, that 100%, you know, and they're, you know, everything. They have doctors, nurses, all kinds of people. It's not just doctors that support magisterial teachings. And so we do have a very small portion of doctors that want to practice according to church teaching. There's the Catholic Psychotherapy Association, Catholic therapists. So, you know, we'll stand our ground as long as we're allowed to. So we'll see what happens. All right.
Thank you.
Thank you very much.
Because genetics has changed so much, I thought I'd like throw, you know, research. I guess there's some evidence saying that the science is still skeptical. You know, like, is it related to genetics or not? So I mean, I guess we'll see, but I just know. Something about thyroid function, which like hormonal, of course.
Hormonal.
Something like that. So it's all still kind of like a big combination.
There could be, exactly. So there could be hormonal factors, but that's not the norm. It's usually psychological, environmental, nature versus nurture. You know, the genetic part has not definitely been proven. Although it could be, and even with transgender, you know, there are people who are intersex. They literally have both gonads, like it's a genetic issue. Exactly. Yeah. But it's such a small population that this other psychological and social contagion thing is just taken over. So if there's no further questions, I think that's it, right? He's going to talk about this. This is another huge subject. You're welcome. And I will actually send the new slides to Father so that he can